Welcome back to the library. Or, considering the stack of books in front of us, maybe I should say, welcome back to the trenches.
Yeah, that's a good way to put it.
We are deep in the revision bunker today. We're taking the heavy artillery Miller's anesthesia, Morgan and Mikhail, Yao and Artuzio, and of course those life-saving ICU protocols, and we're distilling them for one singular objective.
Survival.
Exactly. Our survival in the MD anesthesiology final exams.
It does sound a bit dramatic when you say it like that, but, for a postgraduate student, the exam hall really is a kind of battlefield.
It definitely feels that way.
And today's topic, it is the ultimate test case. If I were an examiner at Gujarat University, or frankly, any rigorous board, and I wanted to test a candidate on physiology, pharmacology, physics, and clinical judgment, all in one 20-minute station.
There's only one topic you'd choose.
Only one. Cardiac pacemakers.
Cardiac pacemakers. It's the perfect storm, isn't it?
It absolutely is. You've got complex electrical circuits. It tests your fundamental understanding of cardiac output. And it has that terrifying potential for things to go very wrong intraoperatively if you're not paying absolute attention.
Right.
So for the next hour or so, I'm not just your co-host. Let's frame this. Consider me your senior faculty. You are the postgraduate student. The exam is looming.
I can feel the sympathetic surge already. The mission is clear then. Convert these thousands of pages into a concise, high-yield audio revision guide. We're targeting that 20-mark long question.
Or that high-pressure viva voce.
Yes, where the external examiner just slides an ECG across the table with a little spike on it and then just waits.
And waits for you to crumble. But we won't let you crumble. We are going to break this down systematically. We'll follow the exact structure you would need for a gold medal answer.
Okay, where do we start?
We'll start with the basic electrophysiology.
Yeah.
You can't explain a pacemaker if you don't understand what it's replacing.
Makes sense. The biology first.
Then the classifications. The NBG codes, which are, let's be clear, non-negotiable. And the real core of the discussion. Anesthetic management. Specifically, how to handle electromagnetic interference, or EMI.
All right, Professor, let's set the scene. I'm sitting in the theory hall. I turn over the paper, and question 1 is, classify pacemakers and discuss the anesthetic management. Part A of our outline. Introduction and exam framing. Where do I even begin?
You begin with a precise definition. Your opening sentence, especially in a written exam, it sets the tone for everything that follows.
So, no, it's a machine that makes the heartbeat.
Absolutely not. That's not going to fly. You need the textbook definition.
Okay, so what is that perfect opening line?
You write, a pacemaker is an implantable cardiac pulse generator.
Implantable cardiac pulse generator. Got it.
Its primary function is to treat bradyarrhythmias. And it does this by delivering low-energy electrical pulses to depolarize the myocardium, which then initiates a mechanical contraction.
Simple, elegant, accurate. I like it. But when I look at the sources, especially Miller, it seems like the scope of pacemakers has just exploded recently. It's not just about stopping the heart from, stopping anymore.
No, and you must mention this evolution. It shows you're well-read, that you're current. Historically, yes, it was all about preventing Stokes-Adams attacks, those sudden collapses from bradycardia.
Right.
But modern care has shifted massively. We've gone from these simple fixed-rate devices to incredibly sophisticated rate-responsive units. And now, the biggest paradigm shift is towards biventricular devices.
Cardiac resynchronization therapy, CRT.
Exactly. CRT for heart failure.
So if I'm framing this for the examiner, I need to stress that it's not just a rhythm device anymore. It's also a hemodynamic optimization device.
Precisely. And that brings us to the next critical point. For us, the anesthetist, why does all this matter? I mean, apart from the obvious don't let the patient die rule.
Yeah, right. The prime directive.
It matters because the operating room is a hostile environment for these devices. It's just inherently hostile. We introduce chaos into what is supposed to be a very controlled system.
We bring the noise.
We bring the electrical noise with electrocautery. We bring physiological changes, hypoxia, electrolyte shifts, all the drugs we use that can alter conduction. So anesthetic relevance is about preventing hemodynamic collapse when that device is challenged. In the exam, you have to show you understand that interplay.
So I'm not just a technician watching a monitor.
You are the guardian of that rhythm. That's the mindset.
Okay, let's move to part B, basic electrophysiology. If I'm writing that long answer, I assume I can't just jump into the machine. I need to explain the biology first, what's gone wrong.
Correct. And this is flagged as very high yield for a reason. You must briefly but accurately recap the normal conduction system. You have to visualize the anatomy. It all starts at the SA node.
Sinoatrial node, the natural pacemaker.
Right. located right at the junction of the superior vena cava and the right atrium. And it's the boss, because it has the highest intrinsic rate of automaticity.
And from there, the impulse travels to?
The AV node, the atrioventricular node.
The gatekeeper.
The gatekeeper, I like that. Its whole job is to delay the signal for a fraction of a second.
And that delay is crucial.
Absolutely crucial. It's what allows the atria to contract fully and push their blood into the ventricles, the atrial kick, just before the ventricles fire.
So it optimizes filling.
It's all about optimizing preload. From the AV node, the signal shoots down the His-Purkinje system for that rapid synchronous ventricular contraction we need for an effective heartbeat.
Now, Morgan and McCall makes a really big deal about the difference between the action potentials in the nodes versus the muscles. Is this something I really need to drill down on for the exam?
If you want to distinguish yourself from an average candidate, 100% yes.
Yeah.
You need to talk about the pacemaker potential. In the SA and AV nodes, we have what's called a slow response action potential. And the key is that phase 4, which should be the resting phase, isn't flat. It slopes upward spontaneously.
And that upward slope, that's due to the ion channels, right? The funny current?
Yes. The funny current, or is the slow leak of sodium ions into the cell. Then, as it gets closer to threshold, transient calcium channels open up. When it finally hits threshold, around minus 40 millivolts, you get the upstroke. But here is the critical point.
What's the upstroke dependent on?
It's calcium dependent. It's the L-type calcium channels that are responsible for the depolarization in the nodal cells.
Whereas the myocytes, the actual muscle cells, they have a fast response.
Correct. They have those fast sodium channels that just snap open for a very rapid depolarization.
Right.
Now, why does any of this matter to an anesthetist?
Well, our drugs must affect these channels differently.
Exactly. Our volatile anesthetics, sevoflurane, oselflurane, they depress that SA node automaticity. They literally flatten that phase 4 slope.
So if I have a patient who is, let's say, already bradycardic or has some sinus node dysfunction, and I do a gas induction,
You might tip them over. You could precipitate profound bradycardia or even a sinus arrest.
wow.
And here's a classic Viva trap involving atropine. Let's say you've done that, you've caused bradycardia, and you give atropine to fix it.
Okay, sounds reasonable. Block the vagal tone.
It does. But in a patient under deep anesthesia, you might accidentally trigger a junctional rhythm.
Yeah.
Why? Because you've removed the vagal input, sure, but the SA node is still depressed by the gas. The junctional pacemakers, which are less affected, speed up more, and suddenly they take over.
And you get AV dissociation.
You've created AV dissociation. It's a classic physiology trap that separates the good candidates from the great ones.
That's a fantastic point. Okay, let's look at the indications for pacemaker insertion. This is marked as exam core.
And it is. If an examiner asks this, or if you're writing it in your paper, you need to structure your answer using Class I indications.
Class I being the ones where the benefit massively outweighs the risk.
The absolute non-negotiable indications.
So what are the top 3 I should have ready to list?
Number 1, symptomatic bradycardia. This is usually due to sinus node dysfunction, what we often call sick sinus syndrome. The patient feels dizzy, they faint, they can't exercise.
Okay, symptomatic bradycardia. Number 2.
Complete heart block or third-degree AV block. The atria and the ventricles are completely divorced electrically, they're beating independently, and the ventricular rate is dangerously slow.
And the 3rd one.
Mogut's type 2 second-degree block. This is the dangerous one. It happens below the AV node in the His-Purkinje system.
Why is it so much more dangerous than Mobitz thirst?
Because it can suddenly and without any warning progress to complete heart block and asystole. Mobitz thirst is usually benign. Mobitz thirst is a ticking time bomb.
I noticed in Miller there's a huge section now on heart failure as an indication.
Yes, this is the third pillar of modern pacing, as we mentioned. Cardiac resynchronization therapy, CRT. You have to talk about this.
So who gets CRT?
It's for patients typically with a left bundle branch block or LBBB and a low ejection fraction. Usually the cutoff is less than 35%.
Okay, LBBB and low EF. What's the pathophysiology there?
With LBBB, the left ventricular lateral wall contracts late. It's out of sync with the interventricular septum. So the heart isn't squeezing efficiently, it's kind of wobbling.
Like an engine with a misfiring piston.
That's a perfect analogy. A biventricular pacemaker puts leads on both the right and left ventricles and paces them simultaneously. It resynchronizes that squeeze.
Narrows the QRS, improves the EF.
Exactly. It's a game changer for heart failure. So, for your exam paper, if you want to get top marks on indications, you should list acquired AV block, sinus node dysfunction, and one more keyword.
Chronotropic incompetence.
Chronotropic incompetence. The examiners love that phrase. It means the heart rate fails to increase appropriately to match metabolic demand.
You run for a bus, but your heart rate just stays at 60.
Right. Your muscles are screaming for oxygen, but the heart isn't responding. That's a clear indication for pacing, specifically rate-responsive pacing.
Excellent. Okay, we've framed the problem. We know why someone needs one. Let's talk about the hardware itself, Part C. Types of pacemakers. This feels like an area where classification is absolutely key.
Always classify. An organized mind gets more marks. So you start with a temporal classification, temporary versus permanent.
Okay, temporary is for emergencies, right? Or as a bridge to getting a permanent one.
Yes. Transvenous is the one we see most in the ICU or CCU. A wire is floated up the femoral or jugular vein and positioned in the RV.
But don't forget the other temporary types.
You can't. You've got transcutaneous, those big pads we slap on the chest during a code. They work, but my God, they're painful for a conscious patient.
And epicardial.
Yes, the little fine wires you see coming out of a patient's chest after open heart surgery, they're sutured directly onto the epicardium.
Okay, so that's temporary. And permanent pacemakers are the implanted generators, usually in that infraclavicular pocket.
Correct. Now, how do we classify them by chamber configuration?
This is about where the wires, the leads, actually go.
Exactly. So the simplest is single chamber, one lead. Usually it's in the right ventricle, so it's VVI pacing, or sometimes in the right atrium for isolated sinus node dysfunction.
And dual chamber.
Two leads, one in the right atrium and one in the right ventricle. This is your workhorse for maintaining AV synchrony.
And the third, the more advanced one.
Biventricular for CRT. That's three leads, one in the RA, one in the RV, and then the third special lead is threaded through the coronary sinus to sit on a vein on the outside of the left ventricle.
So you can pace that lateral wall and resynchronize the contraction.
Precisely. You're correcting the LBBB electrically.
Okay, now we hit what the outline calls exam gold. The pacemaker modes, the NBG code. I'll be honest, this is where a lot of us get tripped up.
And you cannot afford to. If you do not know the NBG code, you cannot pass this station. It's that simple. It stands for NAS-PEG Generic Code.
NAS-PEG?
It has 5 positions, but for the exam, you really need to be rock solid on the first 3, maybe 4.
Let's unpack them slowly then. Position I.
Position I is the simplest. Chamber paced. Your options are O for none, A for atrium, V for ventricle, or D for dual, meaning both. This tells you which chamber gets the electrical jolt.
Okay, paced. A, V, D, position 2.
Chamber sensed, same letters, O, A, V, or D. This tells you where the device is listening. Where is it looking for the patient's own intrinsic electrical activity?
Okay, paced, sensed. Now the tricky one, position 3. Response to sensing.
This is the logic gate. The options are O for none, I for inhibited, T for triggered, or D for dual, which means it can do both.
Okay, let's make this practical. Let's take VOO mode.
Good, let's break it down. VOO, paced, ventricle sensed, none. Response to sensing, none.
So it's just firing blindly into the ventricle.
Exactly. It is asynchronous.
Huh?
It will pace the ventricle at a fixed rate, say 70 beats per minute, completely, regardless of what the patient's own heart is doing. It ignores the intrinsic rhythm.
That sounds dangerous. Couldn't it fire on a T wave?
It absolutely can.
Yeah.
In a conscious patient with an underlying rhythm, you risk the RNT phenomenon, which can trigger ventricular fibrillation. However,
there's a time and a place for it.
there is. VOO is often exactly what we want during surgery when the surgeon is using electrocautery.
Ah, because we wanted to ignore all that electrical noise from the cautery.
Precisely. We accept the very small risk of RNT to avoid the massive risk of the pacemaker seeing the cautery, thinking it's a fast heartbeat, and shutting down completely.
Inhibition, right. Okay, let's contrast that with the most common mode, VVI.
EVI. Let's do it again. Paces the ventricle,
Mm-hmm.
senses the ventricle, and the response is inhibited.
So it's a demand mode.
It's a demand mode. It listens. If it hears a native heartbeat from the ventricle, it holds its fire. It inhibits itself. If it hears silence for a programmed period of time, then it paces. This is great because it prevents competition.
But there's a famous downside to VVI, isn't there? The pacemaker syndrome.
Yes, and you need to be able to explain this. In VVI mode, you're ensuring the ventricle beats, but the atria are still doing their own thing. You've lost AV synchrony.
You lose the atrial kick.
You lose the atrial kick, which can be 20 to 30% of your cardiac output, but it's worse than that. The atria might contract at the exact same time as the paced ventricle, meaning they're contracting against a closed tricuspid valve.
So the blood has nowhere to go but backwards.
Backwards into the jugular veins, you get Canon A waves in the neck, hypotension, dizziness, profound fatigue. That is pacemaker syndrome.
So to fix that, you need a dual chamber mode like DDD.
Now you're thinking. DDD paces both, senses both, and the response is dual, meaning it can inhibit or trigger. It's the most physiologic mode. It listens to the atrium. If the atrium fires, it waits a normal PR interval, then checks the ventricle. If the ventricle hasn't fired on its own by then, it paces it.
So it maintains that crucial AV synchrony.
It does everything it can to mimic the natural conduction system.
And what about position 4, the R?
That's for rate modulation. A device with an R in its code, like VVIR or DDDR, has a sensor inside. It could be an accelerometer that detects motion, or a sensor that measures thoracic impedance to estimate minute ventilation.
So it knows when you're exercising.
It knows when your metabolic demand is up, and it increases the pacing rate accordingly. It restores that chronotropic competence we talked about.
That's a great breakdown. Let's move to Part D, function and features. We've talked about the generator and leads a bit, but Millie gets into the weeds on things like thresholds. This feels like a potential Viva question.
It's a classic Viva question.
Yeah.
There are two thresholds you must know. The first is the capture threshold.
That's the minimum energy needed to actually make the heart muscle contract, right?
Exactly. The minimum amount of energy, we measure it in volts or milliamps, that you need to deliver to reliably depolarize the myocardium. And in practice, you always set the device's output to be well above that threshold.
The safety margin.
A safety margin of 2 to 3 times the threshold. Because things like electrolyte changes or new medications can make the threshold go up.
And the second threshold is the sensing threshold.
Correct. This is the minimum voltage of the intrinsic electrical signal, the patient's own P wave or R wave that the device needs to be able to see. It's about sensitivity.
And you can get this wrong in 2 ways.
2 ways. If the sensing threshold is set too high, you're making the device less sensitive. It might miss the patient's own small heartbeats and pace right on top of them. That's undersensing.
And if it's set too low?
It becomes too sensitive. It might mistake electrical noise or T waves or muscle twitching for a real heartbeat and then inhibit itself when it shouldn't. That's oversensing.
Which leads us perfectly to the concept of pacemaker dependence. The outline calls this an exam favorite. How does Miller define it? I feel like this is a line I should just memorize.
You should absolutely memorize this definition. The absence of a perfusing rhythm without pacing.
So if the machine stops, the patient either flatlines or their heart rate drops so low that they have no effective blood pressure.
That's it. Identifying dependence is the single most important step in your preoperative assessment. It dictates your entire management plan.
So how do I know for sure if a patient is dependent? History helps, I guess.
History is a big clue. Did they have syncope or cardiac arrest before the device was implanted? That's a red flag.
And on the ECG.
The ECG can be suggestive, but not definitive. If you see that every single QRS complex is preceded by a pacing spike, they are 100% paced. That suggests dependence, but it isn't proof. They might have a slow but stable underlying rhythm that's just being suppressed.
So what's the real test?
The only way to know for sure is to, under controlled conditions, turn the pacemaker's base rate down.
Slowly.
Very slowly, with full monitoring and resuscitation equipment at the bedside. You turn the pacer rate down from 70 to 60 to 50, and you watch. If an underlying rhythm emerges, even if it's slow, they're not strictly dependent.
But if you turn it down to 50 and all you see is a flat line between the pacing spikes,
Then they are dependent. And your entire anesthetic plan has to be built around that fact. No mistakes allowed.
Okay, that's crystal clear. Let's step into the clinical scenario. Part E, anesthetic management. I'm in the pre-op clinic. A 65-year-old gentleman, pacemaker in situ, is scheduled for a laparoscopic cholecystectomy. What's my first move?
The check the card rule. Every patient should have a card from the manufacturer in their wallet. You need 4 pieces of information from it.
Okay, what are the 4?
Manufacturer, is it Medtronic, a St. Jude, a Boston Scientific model? Mode, is it VVI, DDD, DDDR? And crucially, the indication.
Why is the indication so important? I know the mode.
Because a patient who got the pacer for sick sinus syndrome might have a stable, albeit slow, junctional escape rhythm of 40 BPM if the device fails. But a patient who got it for complete heart block after an AV node ablation might have no escape rhythm at all. The indication tells you what the stakes are if something goes wrong.
Right, it tells you what the underlying rhythm or lack thereof is. What if they lost the card?
Then you become a detective. You get a chest x-ray. The shape and size of the generator can sometimes give you a clue to the manufacturer. More importantly, you zoom in on the can itself. Many devices have a radio-opaque code embedded in them that you can look up.
And you can see the leads on the x-ray.
Exactly. Is it 1 lead or 2? Are they intact? You're looking for fractures or dislodgement.
Physical exam, Anything specific?
You're looking at the pocket itself. Are there signs of infection or erosion? And you're doing a general cardiac exam. Are there signs of heart failure? Is the device actually doing its job of keeping them hemodynamically stable?
What about labs?
Electrolytes, specifically potassium.
Why potassium?
Hypokalemia makes the heart muscle harder to stimulate. It hyperpolarizes the cell membrane, which increases the capture threshold. You can have a situation where the pacemaker is firing correctly, but it's failing to capture the myocardium.
So you see spikes, but no QRS.
Spikes with no QRS. A nightmare scenario. Hyperkalemia can also cause problems, but hypokalemia is the classic exam question. So normal electrolytes are absolutely non-negotiable before surgery.
Okay, let's move into the OR. Intraoperative considerations. This is where the rubber meets the road. Monitoring.
Let's be very clear about this. The ECG tells you about electricity. It does not tell you about pumping.
So you can have electrical capture without mechanical capture.
You can have a perfect-looking ECG with a pacing spike followed by a QRS complex, but the patient has no pulse. It's a form of pulseless electrical activity, or PEA.
So I absolutely need a pulse oximeter, or even better, an arterial line.
It is mandatory.
Yeah.
Your ECG is going to be a mess of uninterpretable fuzz the second the surgeon steps on the cautery pedal. The plethysmograph waveform on the pulse ox or the arterial line trace is your only reliable confirmation that each electrical spike is actually producing a pressure wave.
Pulse shows pumping. I need to write that on my hand.
You do. It's your lifeline.
Yeah.
Now let's talk drugs. Secacinylcholine.
Always controversial.
Yes. The traditional teaching is to use it with extreme caution or avoid it entirely in a pacemaker-dependent patient.
Because of the fasciculations?
Exactly. The widespread muscle twitches generate low-frequency electrical signals, myopotentials.
And the pacemaker might see those twitches.
It might see that electrical noise, interpret it as a very fast intrinsic heart rate oversensing, and in an inhibited mode like VVI or DDD, it will shut down pacing.
So the patient goes into a systole for the duration of the fasciculations.
A terrifying thought. While some modern devices have better filters, the classic teaching and the safest exam answer is that rocuronium is a much safer bet.
What about an induction agent like ketamine?
Ketamine can be a good choice. It's a sympathomimetic, so it supports heart rate and blood pressure. However, you need to be cautious if the patient has severe coronary artery disease, as it increases myocardial oxygen demand.
Okay, now for the big one. The topic that takes up half the chapter in Miller. Electromagnetic interference, or EMI. Specifically, electrocautery.
This is public enemy number one for pacemakers in the operating room. The cautery tip delivers high-frequency radiofrequency energy to cut or coagulate tissue.
How does that confuse the pacemaker?
It can cause chaos in two main ways. The first and most common is oversensing. As we just discussed, the pacer's sensing circuit can interpret that RF noise as a rapid intrinsic heart rate.
And in VVI mode, it inhibits.
It inhibits. The patient, if dependent, flatlines. The second risk is that a strong enough surge of energy, if it passes right through the device, can actually damage the circuitry or reprogram it to some random backup mode.
The outline mentions bipolar versus monopolar. This seems to be the key to managing the risk.
It is your primary defense. You must communicate this to the surgeon. Bipolar cautery is safe.
Why is it safe?
Because the electrical current travels only a few millimeters between the two tips of the forceps. The circuit is tiny and contained. It doesn't travel through the patient's body.
But surgeons often prefer monopolar.
They do, for large-scale dissection. With monopolar, the current flows from the active electrode, the bouvis, tip through the patient's body, all the way to a large grounding pad, usually placed on their thigh.
And if the pacemaker generator and leads lie within that pathway,
You have a major problem. You're basically running a river of electricity right past the device.
So what are my precautions? What do I tell the surgeon?
Rule 1. Request bipolar whenever possible. Rule 2. If they absolutely must use monopolar, the placement of the grounding pad is critical. You must place it so the current path does not cross the chest. For abdominal surgery, put it on the thigh. The current goes from the belly to the thigh, away from the heart.
Makes sense. Any other rules?
Yes. Short bursts. Tell them to pulse the cautery, less than 4 or 5 seconds at a time. This gives the pacemaker a chance to recover and pace if it's being inhibited. And Rule 4. Use cut mode rather than the coag mode if possible.
Why is that?
Coagulation mode uses a more intermittent, higher voltage current, which creates more interference. Cut mode is a more continuous, lower voltage waveform.
Okay, but what if my patient is 100% pacemaker dependent? Even with all these precautions, I can't risk even a few seconds of inhibition.
Correct. In that situation, you cannot rely on the device's normal sensing function. You have to make the pacemaker ignore the interference completely. You need to put it into an asynchronous mode,
VOO or DOO?
VOO or DOO. And you can do that by having a technician come and reprogram it, or by using the magnet.
The magnet. A source of endless confusion and a classic Viva trap.
It is. Let's clear this up once and for all, because getting this wrong in an exam is a major red flag.
Okay, let's do it. What does a magnet do to a standard pacemaker?
In the vast majority of modern pacemakers, placing a special donut-shaped therapeutic magnet directly over the generator closes a reed switch inside. This forces the device into a fixed-rate asynchronous mode, usually VOO or DOO, at a specific magnet rate.
Which is often something like 85 or 100 beats per minute, right?
Exactly. It's a preset rate. So by applying the magnet, you have effectively blinded the pacemaker to the cautery. It will keep pacing at that fixed rate no matter what noise it hears. This protects your dependent patient from inhibition.
And this is the big trap. What does a magnet do to an ICD, an implantable cardioverter defibrillator?
This is where candidates fail. A magnet placed over an ICD generally suspends the anti-tachycardia therapies. It turns off the shock function and the anti-tachycardia pacing.
Which you want so the cautery doesn't trick it into delivering a massive shock.
Correct. But here's the crucial part. It usually does not change the bradycardia pacing mode to asynchronous.
Wait, say that again? That's critical.
A magnet on an ICD turns the shocks off, but the pacemaker part of it often remains in a sensing mode, like VVI or DDD.
So if I have a pacemaker-dependent patient who has an ICD and I just put a magnet on them during surgery?
You've protected them from an inappropriate shock, which is good.
What?
You have not protected them from pacemaker inhibition by cautery. The pacing could still stop.
That is a massive distinction. So for that patient, the dependent patient with an ICD undergoing surgery with heavy cautery, a magnet, is not enough.
It is not sufficient. For that high-risk patient, the gold standard is to have a cardiology technician come and formally reprogram the device. They will turn off the tachytherapies and set the pacing mode to a non-sensing asynchronous one like VOO.
And if there's no time for that,
then you must have external pacing pads on the patient and be ready to use them the instant you see inhibition on your arterial line.
Speaking of external pacing, Miller is very clear that we must have backup available.
Always. For any pacemaker-dependent patient, defibrillator pacing pads go on the patient before induction.
And the positioning matters.
Anterior-posterior is generally preferred as it gives you the best vector for capture. But do not place the pad directly over the implanted generator. You could damage the device if you have to deliver a shock.
Okay, let's move to part F, postoperative care. The surgery is done, we survived the cautery, what now?
First things first, if you used a magnet, take it off. As soon as EMI is no longer a threat, remove the magnet. The device should automatically revert to its previously programmed settings.
And if we had it reprogrammed?
You do not send that patient from the recovery room to the ward until the technician has returned and reprogrammed the device back to its chronic settings. That's a critical safety handover.
There's a note in my outline here about the shivering trap.
Ah, yes. This is a clever one. It relates to rate modulation. Remember we talked about the R mode with the sensors that detect vibration to increase heart rate.
Right, for exercise.
Well, what is shivering? It's a massive amount of muscular vibration. The pacemaker's accelerometer can't tell the difference between shivering and jogging on a treadmill.
So it thinks, oh, we're running a marathon.
And it drives the heart rate up to the maximum programmed limit, maybe 160 or 170 beats per minute. In a post-op patient with coronary artery disease, that could be enough to cause a myocardial infarction.
Or, conversely, the myopotentials from all that shivering muscle could be oversensed and cause inhibition, couldn't they?
Exactly. It can go either way, and both are bad. So the take-home message is, treat shivering aggressively in a patient with a pacemaker. Use forced air-warming blankets, small doses of pethidine or meperidine, whatever it takes to stop the shaking.
Great point. Part G, special situations. What about regional anesthesia? Is it a good idea for these patients?
In many cases, it's an excellent idea. It can avoid the whole issue with succinylcholine, the hemodynamic swings of intubation, and it provides great post-op pain control. But you have to be wary of high neuraxial blocks.
Spinals or epidurals that go up too high.
Yes. If your block level reaches T1 to T4, you're going to block the cardiac accelerator fibers. You're giving the patient a chemical sympathectomy.
And that causes hypotension and bradycardia.
Right. Now, the pacemaker can easily fix the rate. If the heart slows down, the pacer will kick in and keep the rate at 70. But it cannot fix the loss of contractility and the vasodilation from the sympathectomy.
So you can have a patient pacing perfectly at 70 BPM, but with a blood pressure of 60/30.
Exactly. And in that situation, you need to be ready with direct-acting vasopressors.
Like phenylephrine.
Phenylephrine is your best friend there.
Yeah.
It directly addresses the vasodilation.
Okay, what about the ultimate high-stakes scenario? Emergency surgery. A patient with a pacemaker comes in after a trauma, needs to go to the OR right now. There's no time to call the cardiology rep, no time to find the card.
This is where you need a simple, robust crash protocol, and you need to have it memorized.
Okay, what is it?
Step 1, assume they are dependent. You have to assume the worst-case scenario.
Okay, assume dependence. Step 2.
Place external pacer pads on them immediately. Your backup has to be in place before the first incision.
Got it. Step 3, surgery starts.
Insist on bipolar cautery. If the surgeon says they absolutely cannot do the operation without monopolar, then you go to step 4. Place a magnet over the device. It's not perfect, especially if it's an ICD, but in a true crash emergency, converting a pacemaker to asynchronous mode is your safest blind bet.
And step 5.
Watch the pulse oximeter and the arterial line like a hawk. Your ECG will be useless. The plethysmograph waveform is your only source of truth.
Assume dependence, pads on, bipolar preferred, magnet if needed, watch the pulse. That's a clear, safe plan.
It'll get you through the emergency.
Part H exam integration. We need to consolidate all this for the final push. The textbooks love comparison tables.
And examiners do too. In your written exam, drawing a simple table can get you a lot of marks quickly. So draw one for temporary versus permanent.
Okay. Permanent. Surgical pocket, internal generator, lower infection risk, used for years.
What about single versus dual chamber?
Another great table. Single chamber, or VBI, is often used for patients with chronic atrial fibrillation, where trying to track the atrium is useless anyway. Right, you just need ventricular backup.
Whereas dual chamber, or DDD, is for patients with sinus node disease, or AV block, where the atrium is still working fine, and you want to preserve that atrial kick for better cardiac output.
Okay, let's hit some of these Viva traps from the outline. The examiner says, I've got a patient in VVI mode and their blood pressure keeps dropping. What's going on?
You answer immediately, that sounds like pacemaker syndrome, sir. Then you explain the loss of AV synchrony and the atrial contraction against a closed tricuspid valve, leading to reduced cardiac output.
Viva trap 2. Does a magnet turn off a pacemaker?
You look the examiner straight in the eye and say, no, sir. In most devices, it does not turn it off. It converts it to a fixed-rate asynchronous mode to protect against inhibition from electromagnetic interference.
Perfect. What about diagrams? The outline says we should be able to draw this stuff.
You should. You don't need to be an artist. Practice drawing a simple schematic of the heart's conduction system. SA node, internodal tracts, AV node, bundle of his, left and right bundle branches.
And for the device itself?
Draw a simple box for the pulse generator. Draw a line coming out for the lead. At the end of the lead, draw the tip electrode touching the myocardium. Then, show the current loop.
This is a key physics concept.
It is. For a unipolar lead, you draw the current loop going from the tip electrode through the body tissue all the way back to the metal can of the generator itself, which acts as the anode.
It's a huge loop.
A huge loop, which is why it acts like a big antenna and is so susceptible to picking up interference. Then, next to it, draw a bipolar lead. The loop just goes from the tip electrode to the ring electrode a few millimeters behind it.
A tiny loop.
A tiny loop, a tiny antenna, much less interference. Drawing that demonstrates a deep level of understanding.
Finally, let's put it all together in a flowchart for Intra-Op Bradycardia in a paced patient. A mental checklist for when things go wrong.
You must have this algorithm burned into your brain.
Walk me through it. The monitor alarms for bradycardia.
Step 1. Check the pulse. Is it real? Feel for a carotid. Look at the arterial line. Is it a true loss of capture or just monitor artifact from the cautery?
Okay, it's real. No pulse.
Step 2. Check the surgical field. Is the surgeon standing on the cautery pedal? Yell, "Stop the cautery!" That might be all it takes.
Cautery's off. Still no pulse.
Step 3. Apply the magnet. If the problem is oversensing and inhibition, the magnet will fix it instantly by forcing asynchronous pacing.
Magnet is on. Still no output. I see spikes, but no QRS.
Step 4. Drugs. This is now a failure to capture. The threshold has gone up. You need drugs to make the heart more excitable. Isoproterenol or epinephrine infusion.
And if that doesn't work?
Step 5. You're out of options with the internal device. Start CPR and activate your external pacer. Turn up the energy until you get capture.
Check pulse, stop cautery, apply magnet, give drugs, external pace. That is a solid, safe algorithm.
It will save a life.
Professor, we have covered a massive amount of ground, from the funny current in the SA node to the NBG codes and troubleshooting EMI.
We have. And if you structure your long answer with these headings, introduction, electrophysiology, classification with the NBG codes, pre-op assessment, intra-op management focusing on EMI and post-op care, you will not only pass, you will impress.
Can we do a quick summary recap? The 15-point recap that was in the outline?
Let's do it. Rapid fire. Are you ready?
Ready.
1. Definition is an implantable pulse generator for bradyarrhythmias.
2. Main indications are sick sinus syndrome, complete block, and Mobitz 2.
3. NBG codes. Position 1 is paced, 2 is sensed, 3 is response.
4. VOO is asynchronous, fixed rate. Good for cautery, bad otherwise.
5. VVI is demand pacing. Safe from competition, but risk of pacemaker syndrome.
6. DDD is the most physiologic, preserves the atrial kick.
7. Dependence means no perfusing rhythm without pacing. This is the key pre-op question.
8. Pre-op, you must check the card for manufacturer, mode, and indication.
9. Check electrolytes. Hypokalemia increases capture threshold.
10. Intra-Op monitoring. The pulse oximeter or arterial line is mandatory. Pulse shows pumping.
11. EMI from unipolar cautery is the enemy. It causes oversensing and inhibition.
12. A magnet on a pacemaker forces asynchronous mode. This is your safety override.
13. A magnet on an ICD only suspends shock therapy. It does not guarantee asynchronous pacing.
14. Post-op. Treat shivering aggressively to prevent inappropriate tachycardia or inhibition.
15. And the golden rule.
Treat the patient, not the device.
That's the one. Don't get so fixated on the box and the codes that you forget to manage the patient's preload, afterload, contractility, and oxygenation. It's all still just basic anesthesia.
Professor, before we sign off, is there one final provocative thought? Something to leave the listener with that takes this beyond just the textbook?
There is. Miller just touches on the future, but it's coming fast. We're already seeing leadless pacemakers, tiny capsules implanted directly inside the ventricle. But the real frontier is biological pacemakers.
What does that even mean?
It's gene therapy. Scientists are using viral vectors to inject genes into normal cardiomyocytes to convert them back into pacing cells, essentially turning a piece of ventricular muscle back into a new SA node.
Wow.
Now imagine your pre-op assessment for that. An anesthetic plan for a pacemaker that you cannot see on an x-ray, you cannot interrogate, you cannot reprogram, and you cannot put a magnet on. That is the future you might be practicing in.
That is both fascinating and absolutely terrifying. Thank you, Professor, for this masterclass.
You're ready for the exam. Just keep those codes straight and remember your algorithm.
And to our listener, good luck. You've got this. Until next time, this has been The Deep Dive.